Good evening, everybody. Thank you very much for joining us live from Paris for this PCR webinar dedicated to the TRILUMINATE pivotal trial, a very important trial, which we will discuss in all details with the principal investigator during this webinar. The webinar is organized by the PCR Tricuspid Focus Group, and I have the pleasure to co-chair this session with Professor Francesco Maisano from Milan. And we also have a fantastic faculty from all over the world. We have Victoria Delgado on the right from Spain. We have Marco Metra from Italy, and online from the US. Thank you very much to both of you for being online in the middle of your day. We have Rebecca Hahn from Columbia Hospital in New York City, and Paul Soraja, the principal investigator of the TRILUMINATE trial from Minneapolis. Thank you to all of you for being here and for your time. And also congratulations, Paul, on this extremely well-conducted trial. Becky, you were the core lab of the trial, so we really have the main investigator here. It is an historical trial, I would say. And I'm sure Francesco agrees on that, because it's the first one to compare a therapy, a treatment of isolated tricuspid regurgitation to medical therapy in patients with isolated secondary tricuspid regurgitation. The learning objective of this one-hour session would be, of course, to learn about the result of this trial in all details, but also to understand how this result will impact on daily clinical practice, and to identify what has maybe not been addressed by the trial so far, the remaining gaps of knowledge and future research areas as well. So thank you very much. It's my pleasure, and let's get started. Francesco, I give you the word.
So let's go already into the details of the discussion. I'd like to introduce Paul Soraja, who has been the primary investigator, and to Paul, I would like to ask a summary of the study, starting from the study design. So, Paul, can you tell us how the study was designed, what were the objectives, and how the methods have been designed for this very new study? This is the first time we have a study on isolated tricuspid, so I can imagine there were a lot of discussions.
Well, thank you very much, Francesco and Fabian, and all of you for the opportunity to be here. It's really an honor and privilege, and to share this with Becky as well, to describe TRILUMINATE and to really think about how this trial has impacted our practice going forward. And it's a real privilege, and I'm happy to be here. So when we look at TRILUMINATE, and if we could have the slides up, you know, the objective of this trial was really to focus on patients with severe symptomatic TR, and really focus on patients who had well-managed left-sided disease or left-sided disease that was not requiring clinical intervention. And so there's been discussion about calling this isolated TR. It is isolated to some extent, but a lot of these patients had morbidities and left-sided disease that was just managed well. And what we did is we took these patients who were relatively well managed. They did have to be on diuretics if possible. And then we randomized these patients to the TriClip device versus medical therapy. And again, I speak to the well-managed aspect in that we required right heart caths in all of these patients, and we excluded patients with severe pH pressures over 70 and patients with wedge pressures over 20. And then today's focus is really on the results of the one-year outcome.
So, Paul, I think to start with, it's very interesting to know exactly who are these patients, what has been the effect of this selection. And so can you show us the baseline characteristics of the patients who are now included in this study?
Yes, and so when we look at this slide here of patients with baseline characteristics, their average age was 79. The majority were women, and quite typical for patients with TR, nearly all patients had AFib. An important call out in terms of the baseline characteristics is the average KCCQ at baseline was around 55, somewhat similar to some other device trials for valvular heart disease. And these patients also had a whole host of morbidities. We can see here renal failure, prior cardiac surgery, aortic mitral interventions. Device leads were present in 15% of the population, and there was just one patient who had previous tricuspid valve surgery. Another important call out, when we look at these patients, is that massive or torrential TR, and a huge credit goes to Becky for spearheading this 5-grade grading scheme. Massive and torrential was present in 71% of these patients. So these are some of the most extreme in terms of pathology of TR. They certainly had to be eligible for the device, but in terms of the anatomical qualifications, but in terms of severity of TR, these are pretty significant. One can see here the gaps that were present. There was evidence of moderate RV dysfunction and moderate RV enlargement and dysfunction. And we can see here that also the patients had preserved EF, which again just speaks to the fact that this is TR in the context of relatively well-managed left-sided disease.
Yeah, so then I think it's important to summarize the outcomes of this trial. Again, we are focusing on 1-year follow-up only patients. We've been randomized between, let's say, so-called guideline-directed medical therapy, we will discuss that, and guideline medical therapy plus TriClip.
Yeah. And so what we found is that in the trial, the trial met its primary endpoint. This is a hierarchical classification in which we looked at death, heart failure hospitalization, and quality of life. And that primary endpoint, which is a demonstrated superiority of the device over medical therapy, was driven almost entirely by improvement in quality of life. And it's pretty interesting because I think we learned a lot. I think, some of us were expecting changes in survival and changes in heart failure hospitalization, and we'll talk about this a little bit more, but these are patients who had TR, and this is an example. So if we look here, the 1-year death rate was about 90% in both arms. And if I were to tell you the 1-year cardiovascular death rate, even in the control arm where most patients had torrential TR, it was only 4.7%. So, it really just shines a light on how TR patients are different from left-sided disease. And here we see HFH is also similar. And this is not because of differences in TR severity. If you look here in the next slide here, the TR severity was hugely different between the two arms as a result of the device. The reduction in TR to moderate or less at 30 days was a pre-specified study endpoint, and that was reached in almost 90% of the patients, and that remained sustained out to 1 year. And if we compare that to the control arm only had 5% or so get to moderate or less. And so these are stark differences in TR severity achieved very early on with the device versus medical therapy. And that was associated with improvement in quality of life without an impact on survival or HFH. And on the right-hand side, there have been some questions about, is this a placebo effect, because there wasn't a sham? And I think that's a fair criticism. But one thing we did do is we looked at the change in TR severity, and it was directly related to the change in quality of life in terms of degrees. And, patients will know if they got the procedure, but they may or may not know what the grade of reduction they got. And here we can see that there's clearly a relation to the number of grades reduction in terms of TR and also the improvement in quality of life. And then the final thing I'll mention in the last slide is that in terms of these results, these are it was an incredible safety profile. And we can talk about that now, Francesco, or later, but this is a very safe device. There was only one mortality, and that was not related to the device or the procedure. There were very few incidences of renal failure. There were no cardiac surgeries for device-related adverse events. There was no thrombosis, no embolizations. There was one left-sided stroke. If we look at bleeding, it was less than 5%, and that remained less than 5% through 1 year follow-up. And there was only one patient who needed a pacemaker, and it was the same in both arms. So I think in terms of the safety, it really is quite remarkable. We did have some patients with single leaflet device attachments, but among those 12 patients, 11 of them still had TR reduction because one can place multiple devices in these patients. So I think it's a pretty remarkable finding that we can improve the quality of life of these patients significantly in an effective and safe way for patients who had few options before.
So thank you, Paul. I think you managed to summarize in a few minutes the main outcomes of this trial, again, which is the first of its kind in the field of right heart failure. We have understood that this is a safe procedure. It is effective. Remarkable is that the control arm has at 1 year still high incidence or unchanged incidence of torrential and severe TR. This is somehow different from what we have seen, for instance, in quad trial, where the control arm has been improving MR with medical therapy. So that opens many discussions. I think when we go into this aspect, I'd like to leave the word to Fabien to discuss a little bit about the clinical aspects of this trial.
Yeah, I think there are many questions regarding to the clinical aspect. But before we go to Victoria, I would like to remind you that we would be very happy to answer your question as well. I see already question coming in. Just ask your question. We will give always a priority to your question. If you want to ask question also to the investigator in the US, they will be happy to answer a direct question as well. But Victoria, first to you. We have seen the baseline clinical characteristic of this patient in details presented very clearly by Paul. You see patients in your echo clinic all the time with tricuspid regurgitation. How advanced are the patients who have been included in that study compared to what you see in everyday practice?
So I think that the TRILUMINATE study has included these patients that when you look at the clinical characteristics, they perhaps do not completely match on what we see, for example, on echocardiography. So we see that these are patients with a lot of comorbidities, with asthenia, with renal failure, and they don't respond to medical therapy as we have seen in the control group. But then when we look at the echocardiography, for me, what it comes to my attention is the grade of severe tricuspid regurgitation that they have and the degree of dilatation of the right ventricle and the annulus. If we compare, for example, with the CTSN trial, which was completely different population, no heart failure, the annulus there was around 42 millimeters, and here is more or less about the same. So there must be some anatomical factors or other types of remodeling that make this tricuspid regurgitation be completely incompetent.
It's obviously it is a special population. If you mention the CTS trial, is a trial on a surgical secondary TR in patients undergoing mitral interventions, and obviously this has an impact on patient characteristics. Again, we are learning about this pathology, and I think this trial is a good learning for us, and that's why I would like to involve now Marco Metra as a heart failure specialist. I'd like to know your opinion about these outcomes, these results. The heart failure community obviously has been always looking at mainly at mortality and heart failure hospitalization as a strong endpoint. How convincing is this trial at 1 year only with some improvement of quality of life?
Yes, thank you for your question. So first of all, as Paul was stating before, this is not a heart failure population. It's not typical heart failure population. These patients had mainly, mostly isolated tricuspid regurgitation. Left ventricular function was normal. The ejection fraction was normal. and also they had no pulmonary. Patients with pulmonary hypertension were excluded. So this is a different patient population. Then, of course, if we apply the parameters that we apply in heart failure and also in the guidelines, these we are too much used to think about just mortality and heart failure hospitalizations. And therefore, also the guidelines are heavily influenced by the results on mortality and heart failure hospitalizations. However, and maybe we will discuss this later, heart failure hospitalizations and deaths occurred at a low rate in this trial, at least in the first year. And therefore, the trial was underpowered to have significant results with this respect. On the other hand, as an heart failure specialist also, I must remember that most of our patients, above all when they are heavily symptomatic, they strongly prefer quality of life versus hospitalizations and even duration of life. It's better living better than living a miserable life for a few months more. So quality of life is really an important and sometimes the most important endpoint for also the patients with heart failure, and having a device, a procedure that improves quality of life so consistently as in this trial is of major value for our patients.
I think what also this data tell us is that these patients have a very poor quality of life, and still they do not require hospitalization. So again, we are talking about a special population. Is one of the many subgroups of tricuspid regurgitation patients, because we know probably we have always to make this clarification. We've learned in the last years, particularly within the PCR focus group, which has been including different specialists from different backgrounds, that these patients may have very different patient journeys. Some patients coming from surgery, for instance, they have a typical secondary TR in the context of pulmonary hypertension after left-sided disease. The patients that maybe you see in the heart failure clinics, these are REF patients with mainly left heart disease and hypertension. These are patients with FPEF. The left heart is almost normal. Most of them are elderly with atrial fibrillation. We try to call them atherogenic TR. We still have to make a definition. So again, this trial probably has been mainly including patients who are not end stage, but still they have poor quality of life. This is very interesting, in my opinion. So when you see a Kansas City score about 50, this is very low, yes, although these patients do not go often to the hospital. So how do you explain this thing?
More or less in life, you find what you're looking for. And in this case, it seems to me from the outside that the trial was focused on treatment of tricuspid regurgitation, as it is fair and makes sense within an innovative procedure. And this was the first trial, randomized controlled trial in tricuspid regurgitation. So this is very important. On the other hand, TRILUMINATE didn't have as an inclusion endpoint, as an inclusion criteria, previous heart failure hospitalization, high natriuretic peptides. These are the criteria that are commonly used in heart failure trials to enrich the study population for the hospitalization endpoint. Another aspect which is very important to interpret the trial is that almost all TRILUMINATE occurred in the full COVID-19 times. And COVID-19 had a major impact on heart failure hospitalizations. This has been widely shown. Hospitalizations were reduced by about to about 110% of what they were in the previous months. And other trials consistently showed that the analysis of the pre-COVID times yielded positive results, whereas if the COVID times were included, the results became non-significant, because clearly this had a major impact on the heart failure hospitalizations, as COVID was very effective in keeping the patients out of the hospital. This occurred in the trials with iron replacement therapy, the trial with CardioMEM, GUIDE-HF. So, I mean, this has probably had also a major impact on this endpoint. So quality of life was sensitive to the effects of percutaneous treatment of tricuspid regurgitation, but the events were not sensitive enough.
And what about 6-minute walking test?
The 6-minute, it's another issue. It was very much impaired at baseline, did not improve with treatment. On the other hand, you have a study population with 79 years old patients, and of course, age and comorbidities play a major role in this measurement. The other aspect, I think, it's the imputation procedure, giving 0 meters to the patients who had the event, of course, may favor the treatment if the treatment has an impact on the events, but if both arms are similarly affected, this may just increase the noise and the standard deviation of the measurement. So this is what it is.
Yeah, thank you very much, Marco. I think very important and insightful comments, from a heart failure specialist on that helps to interpret the result of the study. So somebody is going exactly in your direction, George, looking at the webinar and saying that it's the beginning of a story, but gives an opportunity to treat patients with very bad prognosis. I would like to go to Becky for 2 questions. One from the audience and another one that is, I think, very important. Becky, you were the core lab of the study. You were actually assessing the patient before the treatment, but also afterwards, which is much more challenging because you have the clip, at least in the treatment arm, you have the clip in the valve. So how strong was the correlation between the improvement of quality of life we have seen and the residual tricuspid regurgitation?
Yeah, I mean, thanks for that question. I do have to, give a shout out to my colleague Nadira Hamid, who did primary reading for most of the trial. Early on, I was doing most of the screening, and then she really has stepped up for the rest of the trial. So I want to just give a little shout out to her. But clearly, what the results showed and what made it into the main part of the document, which I thought was really, really telling, and not put into the supplement, was the stepwise increase in KCCQ improvement with every grade reduction in tricuspid regurgitation. And the increasing grades, the extended grading scheme of including massive and torrential, was designed specifically for the TRILUMINATE trial. And so this came up in some of the early feasibility studies that clearly showed that we were able to reduce by a single grade. Now, the goal of the therapy was to reduce to moderate or less, and that's what ended up getting into the randomized portion of the trial. But indeed, we found that with every grade reduction, there seemed to be improvement in the way patients felt. And this was completely validated by this trial, which I just was extraordinarily pleased to see. It does mean that we do believe we're able to grade both at baseline and following a tier device, which can be somewhat challenging. But also, it does give some, again, proof that the KCCQ may have some validity in determining the amount of reduction of TR. Now, there's still going to be ongoing studies to try and validate KCCQ as far as a metric of both mortality and heart failure hospitalizations in the TR population. So again, not been proven, but this study does at least take the first step in proving that KCCQ has some value in this particular patient population.
Becky, a second question from somebody looking at our webinar. were you able, with all the cases you saw and this correlation with improvement of quality of life based on echo, are you able now to identify criteria for futility? Did you learn something from the study about this, or is that still a matter of debate?
Well, I think we're still doing deep dives into those patients that only got single grade reductions in tricuspid regurgitation. What we've learned from prior early feasibility studies is that it is indeed related to the severity of the disease to start with. And so we hope to be able to learn what the predictors of adequate or successful reduction in tricuspid regurgitation will be. In the past, it has indeed been related to the severity of baseline disease, so massive and torrential, having less success in getting to moderate. But the other criteria that we ended up using for entry into the randomized portion of the trial and did indeed include some of the data that we learned from those early feasibility trials. So the size of the gap, 10 millimeters was typically our limit. And so with the introduction of G4, so the larger clips, this algorithm may need to change. And we've also we changed during the course of the screening process, and Paul can speak to this as well, changed the way that we thought about pacemakers. So in many of the early feasibility trials, the percent of patients with pacemakers is about 35%, so pretty high. And what I think the lower rate of pacemakers in this trial shows is that there are some pacemakers that, despite the fact that they might be impinging on leaflets, may not affect the amount of TR that we can reduce with the TEER device. And so something to really think about, and we will indeed do deep dives into the echocardiographic data.
Thank you very much, Becky. We follow on a question from the chat again, and I would like to ask Francesco about this. So somebody asked us about the symptoms of tricuspid regurgitation, and in the common understanding, I would say that's mainly edema, but not so much shortness of breath. So some of our people in the audience were surprised that we talk about shortness of breath for tricuspid regurgitation. Can you maybe make a comment on this, Francesco?
Yeah, I mean, probably that is one of the typical misleading issues. Shortness of breath can be also misinterpreted with asthenia and fatigue. I mean, a patient who has low cardiac output and is unable to increase the cardiac output with exercise gets fatigue. And fatigue is a typical symptom of severe tricuspid regurgitation. And that underlines overall the issue of designing a trial with some heart failure design in mind. So where we see an NYHA class for tricuspid, we don't know whether NYHA class is a good method to stratify patients with tricuspid regurgitation. So I understand the comment from the audience, but we have been discussing a lot this topic in the last few years, and I think probably measuring quality of life with instruments like the Kansas City is probably a better way, which is entering into the daily discomfort that these elderly patients have because of this this problem, which is associated with some reduction of cardiac output, some minor symptoms. And we have all this experience that these patients remain mildly symptomatic for many years. They can be managed at home, increasing the dose of diuretics until they come to the hospital and they become untreatable because they have been treated for too many years conservatively. So again, we have to learn a lot about this.
So maybe one question for Victoria. You're a fantastic imager, but also a clinical cardiologist. And one of the questions is about the treatment. What was your optimal medical treatment? What is the optimal medical treatment for this patient? How do you treat them if you go for a conservative treatment?
So I think that for these patients, the first that come to our minds is diuretic treatment. Now, it depends on the patient, how the patient appears, if it's acutely decompensated or if it's much more long-term. And we have several trials recently from heart failure on the effect of these diuretics. But of course, there were also ongoing trials as well, and the first results of the usefulness of SGLT2 inhibitors, for example. again, much more for HFrEF and HFpEF, not really evaluated in this population, but as we have been saying, these patients are rather sometimes heterogeneous. They have other comorbidities. They may have more HFpEF. They have more atrial fibrillation. Almost all the patients in the TRILUMINATE had permanent atrial fibrillation that makes a dilatation of the left atrium. So they are a little bit kind of peculiar patients in that sense. But for sure, what comes to our mind is diuretics, and we know the long-term effects of diuretics eventually.
So this is work for Marco Meder and the Heart Failure Society to update the heart failure guidelines on right side valve disease.
Oh, okay, yeah. we're working on a position paper regarding this. And yes, it must be remembered that Kansas City was developed in patients with heart failure caused by left ventricular dysfunction, either preserved or normal ejection fraction, but it was left heart disease. Here we are dealing with a different kind of patients. As you pointed out, these patients do not have pulmonary edema. They do not have an urgent cause of hospitalizations in most of the cases. And peripheral edema may be treated at home or in the ambulatory setting by increasing the doses of diuretics. That's all we have for medical treatment.
Maybe just one remark to Paul. Paul, what was the evolution of medical treatment in the trial? Were there any difference between the medical treatment arm and the device arm you can mention to us?
Yeah, so it was actually really interesting. So in the device arm and in the control arm, the percent use of diuretics was similar, but the dosing in the device arm was less over time. And it happened relatively early, and by the end of the year, about on average, dose equivalents were about 20 milligrams less in terms of diuretics. And I think that's really quite interesting to me because, you know, we saw TR reduction from the device, and it allowed patients to reduce their diuretics, and then the TR didn't come back. And so it'll be interesting to see how that evolves with future follow-up. But I like to think that, you know, getting these patients on lower dose of diuretics does actually improve the quality of life. Diuretics can be difficult to manage, and their side effects I don't think are as benign as we might often think they are.
Thank you, Paul. So now, Paul and Becky, we would like to have your opinion on a couple of patients which have been prepared by Victoria and Fabienne. So let's start. We will show you two cases, and we will discuss on real cases whether they fit into the scenario of TRILUMINATE. So let's start with the case from Victoria.
Thank you very much. I'm my son, Francesco. So the case that I present is a 77-year-old female who has permanent atrial fibrillation, and she was known with rheumatic valvular heart disease since 2016, but it was mild aortic stenosis and mitral regurgitation, but at that moment she had already severe tricuspid regurgitation. It was performed a transesophageal echocardiography that demonstrated the severe tricuspid regurgitation and ruled out other potential causes of this dilatation of the right atrium and the right ventricle and causing the severe tricuspid regurgitation. So, for example, there was no atrial septal defect, there was no pulmonary hypertension. It was performed a left and right heart cath that showed not coronary artery disease and no pulmonary hypertension, and eventually it was performed also a CMR to better characterize the function of the right ventricle and the dimensions of the right ventricle and the right atrium, which showed dilated, the ejection fraction was good, and it was a massive tricuspid regurgitation. At that moment, the patient was offered the possibility to treat her with a surgical tricuspid valve repair or replacement, but the patient didn't want that option. She considered that she could go on with this situation, and eventually the patient in 2021, she had more progression of symptoms, never admitted to the hospital, but since we had more symptoms in terms of edema, there was a new heart team discussion with recommendation again for surgical intervention. Again, the patient didn't want that option. She was treated with azenocumarol, digoxin, valsartan, bisoprolol, furosemide, spironolactone, and dapagliflozin at the moment that we evaluated. This is the transthoracic echocardiography and transesophageal echocardiography. You can see the dilatation of the right atrium and the right ventricle has a vena contracta of 15 millimeters, and the coaptation gap measured on the transgastric view, and the maximum point of no coaptation was 12 millimeters. Here we did a three-dimensional echocardiography to measure also the 3D vena contracta area that was 1.3, and we eventually did the multiplanar reformations to measure the tricuspid annulus, which was very large, but the image quality was still limited. So eventually the patient was considered perhaps for annuloplasty transcatheter and underwent a CT, and the reconstructions were evaluated for a cardioband, where you can see that the annulus of the tricuspid valve is very large. Eventually, the largest band will cover only 66% of the perimeter, and in addition, many of the anchors of the device were very close to the right coronary artery. Since this was the first patient that we referred for potentially this treatment, the company considered that was very challenging case and did not recommend to perform this intervention. You can see here also the dimensions of the right ventricle. The annulus is 53. The largest dimension of the right ventricle dilatation is 63, and the atrium is almost 70. And in addition, there was a very prominent Eustachian valve that eventually for a cardioband would have been tricky to maneuver the catheters.
So this is a case basically with a late presentation after many years of conservative treatment, a large ventricle with large coaptation gap. So case number one. Case number two, Fabien?
Sure. So the case I would like to present is a little bit an older patient, a male patient, 83-year-old. And the patient had actually no medical history. He was never hospitalized before, and he presented with permanent atrial fibrillation. You will see on the image the atrium were severely dilated. You see the number here, 85 milliliter per square meter. And he had actually as the only comorbidity arterial hypertension, of course, the age, and was symptomatic, and that was at least the reason for referring this patient with severe atrial secondary tricuspid regurgitation. You see the area that was measured outside of our hospital, but in a practicing cardiologist, 0.4, with a right ventricular annular dilatation of 43, so not massively dilated right ventricle like the one you have seen presented by Victoria. TAPSI was normal, 22 millimeter, and the patient had actually almost the only pathological biomarker, an elevated NT-proBNP. And he presented with actually a very concrete problem, which he was unable to follow his wife when walking upwards, which was the case before. And he was actually very annoyed by this, and she as well, because she had to wait on him. So we did the right heart catheterization, a left heart catheterization as well, no coronary artery disease. You see that he has just a little bit of pulmonary hypertension, which we interpreted as secondary because of his arterial hypertension with diastolic dysfunction, and he had only amlodipine for treatment of hypertension and a diuretic because he was presenting sometimes with edema during the evening. So that was the situation. You see already a transgastric view here with a coaptation gap that was measured by 5 millimeter. You see in the center of the valve with an anteroseptal component as well of this tricuspid regurgitation. And you see here some tethering of the leaflet, so the clear sign of the annular dilatation. And you see also on this image that the right atrium is extremely big, probably due to the consequences of atrial fibrillation. The left side of the heart was quite normal, a little bit of hypertrophy, but no other valvular disease. We will come back to the treatment later, but Francesco, maybe we want to start with some comments.
Yeah, I would like to ask actually Paul, first of all, these two cases are two real-world cases. Which one of the two is, in your opinion, the most commonly seen in the TRILUMINATE patient population?
Well, they're, first of all, great cases, great imaging, and I thoroughly enjoyed seeing those. Both cases would be possible for TRILUMINATE. Remember, there's a single arm and a randomized arm. The second case is a little bit more typical in terms of the anatomy and presentation of the gaps. The first patient, the gaps are larger, but we don't look at just the maximal gaps, we look at the treatable gaps. So even if it's 12 in one area, we look at the other areas and see if they're less than 10 or ideally less than 7. And if they're treatable and where we can put a clip on and get at least a TR reduction of 1 grade, they could go into the single arm. And if there's an estimation that you can get down to moderate or less, they would go into the randomized arm. And we have placed patients with large gaps such as that into the trial. I think what's really interesting about the first patient is the degree of RV enlargement. It's really quite remarkable. But interestingly enough, RV enlargement was not a criteria in TRILUMINATE. The only thing we looked at is whether there's device compatibility with the leaflet anatomy. And, patient number 1, it's interesting, the gaps are large in some areas, but the coaptation plane runs septolateral in a uniform single line. And I think it's actually quite approachable. So I would just say in summary, patient number 2 is a little bit more typical, but patient number 1 is also a patient we'd consider for the trial.
So, Paul, thank you very much. I think you mentioned something extremely important from the TRILUMINATE trial, so that some patients were not randomized, were not included in the treatment randomization, but they were still included in the trial. Can you tell us more? They will be follow-up this patient with a little bit more difficult anatomy?
Yeah, so, and this is a follow-on to what Becky was saying earlier about in terms of TR reduction. And again, I give credit again a lot to Becky for really pushing us to get this 5-grade scheme into the trial. Because what that does is it allows us to measure gradations of TR that we normally don't measure. And in the single arm, patients are treatable with at least 1 grade reduction. But the committee felt that, well, there's some uncertainty about getting to moderate or less. And so that's the single arm. And we're hoping to have that reported soon, but that's still a work in progress.
So I'd like to ask Becky something more technical now, because we have been debating about coaptation gap in the maximum coaptation gap versus the gap in the treatable area. And since you have been in the core lab, one of the data which is a bit surprising for us is a relatively small coaptation gap overall and a very severe TR overall. Is this coaptation gap in the maximum area of regurgitation or has been measured in the treatable area?
Well, for the most part, it's going to be in the treatable area. But I'm not at all daunted by those questions about severity of disease with a gap of only 5, because remember, these are patients with chronic atrial fibrillation, and we now know, and remember, during the course of the trial, we learned a lot. And we learned about probably who the patients are that we're treating after the trial was designed. And so in eliminating patients that had pulmonary hypertension or residual left heart disease, we now have a population that's probably more atrial functional than ventricular functional. And those patients have a better outcome. And so, unfortunately, Marco's correct. It was not powered to take that into account because we didn't actually know about the differences between atrial and ventricular functional. Now, in atrial fibrillation, it turns out we've now learned from three-dimensional studies, three-dimensional echo, that the dilatation of the annulus ends up occurring more toward the inferior and the posterior region of the annulus, which means that the anterior-posterior gap, the length of the gap, is going to be much larger than the septolateral, than it may be than the septolateral. So I'm not surprised that we can have torrential disease in the setting of septolateral gaps that are doable, that are treatable with a TEER device.
So Becky, now another difficult question for you because you don't know the outcome of these two cases. So according to your experience as an operator as well as the core lab of this trial, what do you think is the outcome in the two cases? Which one has been successful, which one has not been successful, in your opinion?
Well, the definition of success is obviously, up for debate. And we already know that a single grade reduction can result in some significant improvement in quality of life. So, if that is a success, then I think that both will have success.
Aren't you somehow curious about the outcome of these two cases?
Yeah, no, I am, because the one with the large gap, Victoria's case, is indeed one that would be challenging and is a very late, in my mind, a very late stage atrial functional, where they've allowed the atrial fibrillation to go maybe for decades. And now the right ventricle is indeed dilated and looks dysfunctional, slightly dysfunctional. I think the TAPSE might have still been normal, but it didn't quite look normal. And in that setting, just massive amounts of annular and ventricular dilatation. And so those are harder to get. And so my guess is that the second case will have a better reduction in TR.
We will see. We will see, Becky. I mean, regarding grading, because you mentioned that, I think Victoria had a question for you.
Yeah, one of the questions, Becky, was pushing the 5-degree or the 5-grade tricuspid regurgitation because, for example, coming from the guidelines that we try always to push the patients to be referred earlier. If you already pass severe, that means that you are referring the patients very late. So, on the other hand, for example, in the TRILUMINATE trial, as you said that you explained it very well, the gap may not correlate very well with the amount of regurgitant volume because of the reasons that you explained. But again, the tricuspid annular dilatation is not either that much dilated. Perhaps they are dilated in another direction. So how do we measure that? And do we allow to put in the guidelines those 5 grades when we want to refer these patients earlier, perhaps?
Such a great question. I mean, the current guidelines, both ESC, EACTS, and the EACVI guidelines that came out last year, recommend using the 5-grade scale for patients that are being considered for transcatheter therapies. And I would say that is correct, and that if we're looking at just the mild, moderate, severe category that is used clinically, that any patient that a physician feels has moderate TR needs to be moved forward into those valves, those centers that do tricuspid transcatheter devices and are very used to those increased grades and attempting to find the quantitative metrics that may predict those grades and therefore outcomes, we believe. There are a lot of natural history studies now showing basically a continuous hazard with EROA by PISA. And so, PISA we still use, even though we think it's underestimating quite a bit because of the slit-like orifice that we frequently see. And that's why we like to recommend that anytime you think it's even moderate, those patients should have the quantitative measures performed and evaluated by heart teams and valve centers that are used to quantifying.
Okay, so I am very curious about the outcome of these two cases. So let's start with the case from Victoria. So you told us that initially you excluded this patient. The patient refused surgery. You excluded the patient for TriClip. or truncated edge-to-edge repair, and then you attempted the idea of annuloplasty, also was excluded because of vicinity of coronary artery and because of the size of the annulus. So what is left?
So that's a very good question. Actually, initially we didn't consider first the edge-to-edge because we thought that the ventricle was very much dilated and the annulus as well. So we tried the option that perhaps would be more suitable if anatomy was favorable, but eventually the right coronary artery was too close and the annulus too large. So in a way of desperation, we tried to offer the patient a procedure that was edge-to-edge, knowing that perhaps would not be as successful I would expect with eliminating or decreasing the tricuspid regurgitation. In order to make it easier for the interventionalists and for the results, we admitted the patients 2 days earlier to increase the furosemide treatment and the diuresis, and eventually we did the edge-to-edge repair with implantation of 3 devices that eventually eliminated almost every tricuspid regurgitation that was just trace, and without not much increase of the gradient was mean gradient of 3.
So excellent result. Is obviously a complex case, ended up in a 3-clip implantation, but with a good result. That shows that you can go beyond what is considered the limit. Today we're talking about 7-8 millimeters of gap, but this patient, if I remember, was 12, correct?
Yes.
Okay, thank you so much. So difficult to beat,
Yeah,
what do you have?
I am under pressure because I'm supposed to have the easy one. So what we did, and you can see here, of course, we decided to go for edge-to-edge in that case because of the gap and because also of the age of the patient and the availability of the therapy. So you can see that we have implanted the first clip that was Gen 4, so it was an XTV clip implanted in the anteroseptal commissure, but still had a bit of tricuspid regurgitation, probably at least moderate. So we went for a second clip implantation. You can see the situation with actually good angulation of this clip in the posteroseptal part of the valve, and already the grippers down and the leaflet on the second device. Then we close it and had actually a good result. You see a little bit mobility the day after, still this very enlarged atrium, making also grading of residual TR difficult, but I can tell you that the patient did actually very well. It's now 2 years since this procedure, but one of the first Gen 4 patient we did, and he's able now to follow his wife again, which was his goal, much more than living longer.
So this is a new metric for the new trial. Probably, Paul, I'd like to involve you now in the discussion. Obviously, we have seen 2 great cases, and actually it shows that you need to work a little bit more if the patient is more advanced. So the question is, what is the ideal timing for intervention in your opinion at the moment? So after we have now a little bit more information, what would be the ideal timing for considering a truncated edge-to-edge repair in a patient with isolated tricuspid regurg?
Well, I think certainly earlier is always a little bit better than later. I think that, when we look at these patients, when the RV is too far gone, you have to wonder what kind of impact we're having on these patients. But it's really quite remarkable to think that in both those cases that we're improving symptoms and quality of life. I think to Becky's point about looking at the patients who are clinically defined as moderate and often in our practice, I think we're missing them. And I think we need to be more meticulous about quantitating them and really defining whether they're moderate or not. So in summary, what I would say is I think earlier the better, because I think the gaps are more treatable earlier. And we're going to learn a lot in the next couple of years as well, because TRILUMINATE has secondary endpoints at 2 years. There are multiple other pivotal clinical trials that are going on with longer follow-up. We're going to learn about RV remodeling, atrial remodeling, all those things that I think were important clinically. And I think we'll be able to understand where the thresholds are for that timing of intervention better.
Thank you very much, Paul. I have a question for Marco before we slowly conclude. Marco, I think one of the important population is patient with heart failure and associated valvular heart disease. But also, and there is a question from the audience speaking about the population with FPEF, which has been obviously also included into TRILUMINATE. Is that the two populations you see as candidate for this therapy, or what would be your target for this device as an additional tool to treat patients with heart failure?
Yes, absolutely. We may say we have three kinds of population to my mind. What I was used to think about is the patient who has left ventricular dysfunction. We have this model of the patients after an acute myocardial infarction who develops left ventricular remodeling. And in these patients, right ventricular dysfunction and tricuspid regurgitation really is close to the end stage heart failure. And so the procedure may still improve quality of life, I think, but the likelihood of a success of changing the symptoms radically is probably less. Then we have the patient with FPEF, and now we know that these are the majority of the patients that come to our hospitals every day. And these patients, a fraction of these patients have significant tricuspid regurgitation and may benefit. Then we have the patients with atrial disease. These are patients with long-standing atrial fibrillation history sometimes, and these are the patients who may have isolated tricuspid regurgitation, and they are still heavily symptomatic and may benefit from percutaneous treatment. So it's important to think about all these possibilities every time we approach a patient who has symptoms, and now we have a treatment to improve symptoms of these patients that has been shown to be effective and safe.
So fairly broad population of patients actually potentially benefiting from the therapy. There is one question in the chat, maybe the final one for you, Victoria. Is actually a renal failure or liver disease maybe due to congestion? Is that a contraindication, or you can still achieve some improvement in that population of patients, in your opinion?
I think that considering the safety of the procedure, you should consider to go for it. Of course, if the disease, the renal failure and the liver failure may limit the life expectancy of that patient, you need to consider always the pros and cons. But just declining or denying the option to a patient based on those, considering the safety of the procedure, I would not base that. I would discuss with the patient and potentially, if the heart team considers, offer the possibility to perform the intervention if the anatomy is suitable.
Thank you, Marco. You want to react?
Tricuspid regurgitation causes an increase in central venous pressure. And this is a major cause of liver dysfunction, kidney dysfunction, gut dysfunction, so you have less absorption of diuretics, for example, orally. So there is no reason to think that correction shouldn't improve this outcome.
Thank you.
Okay, so
if I could make one comment to Marco's comment. I mean, what we found early on is that anytime we reduce the amount of tricuspid regurgitation on some of these early patients that came to us with even 4 centimeter squared regurgitant orifices, was that they now became diuretic responsive.
Indeed.
So that, the perfusion pressure of the kidney improved, you have less congestion of the liver, all of it improved. And so I agree with all of you that these should be patients that aren't excluded. We did exclude because we were trying to obviously look at the outcomes related to tricuspid regurgitation reduction and not to liver failure. So they were excluded, but I do think that they benefit.
Absolutely.
So Becky, thanks a lot. First of all, I'd like once more to thank both Paul and Becky to be part of this webinar, because and to have given us some light to illuminate or to triluminate the dark side of the moon. Obviously, this is very early learning in a new disease, which is something which has been left a little bit on the side in every one practice. This trial, I think, is an important first trial in the field. What we learned today, I think, from Paul, we have been able to get a good summary of the design of the trial, including the randomization model as well as the registry. We have been also able to understand the main outcomes. The outcomes always open the door for a number of discussions, and I'm pretty sure that there will be ongoing discussion in the next months, maybe years. Let's see if 1, 2, 3 years follow-up will be different. We also have been able to discuss the consequences on our clinical practice. We have seen some cases from the real world, and we have been discussing about the gaps which are still there, have to be understood. We need to work more. So in general, this is a study which have been positive to tell us a few things. Number one, tricuspid regurgitation is associated with very bad quality of life, although these patients are still not hospitalized. So these are patients who are living outside of the hospital in bad quality of life. Quality of life can be improved by this therapy, although this has to be proven probably with the other studies. But there has been a dose effect on reduction of TR and quality of life improvement. It is a very safe procedure, so this is also an important feedback for getting patients a bit earlier rather than in the past. In surgery, unfortunately, we only got patients too late. So overall, I think is the beginning of the story, is the first randomized trial in isolated tricuspid regurgitation patients comparing medical therapy to a treatment. Several other trials are coming, so I think the field is open. It was a great pleasure to be with you, with Fabienne, Victoria, Marco, and particularly with Paul Suraj and Becky Ann. And I thank everybody for your attention, and I look forward to meet you again in another webinar of the PCR Tricuspid Focus Group.
Thank you, Francesco. Thank you, everybody. Thank you.
Bye-bye.
Bye.
Bye-bye, Becky and Paul.
Thank you.